Conference room number accepted. If you are the organizer, press the star key now. Otherwise, please hold. This line is now muted. This conference will now be recorded. For a menu of available commands, press star 1. There are 18 participants in the conference.
Health system in rural Minnesota for 5 years and one of the largest integrated delivery systems in Minnesota for 10 years before joining the Minnesota Hospital Association as its very first Chief Medical Officer in 2015. A primary care physician at heart, Dr. Khurani has worked in all the settings of care across the care continuum. Dr. Khurani's passion lies in creating optimal health for every individual and helping engineer a nation-leading health system. Now I'll turn it over to Dr. Khurani.
Thank you very much, Kim. Good afternoon, everybody, for joining us on this dialogue and reflection on the phenomenon of healthcare burnout. I really appreciate being here and sharing some of what we are learning here in Minnesota with all of you. So the chat box, I think, is open. So if you have any questions, I'll keep an eye on that and respond as we go. And hopefully what I'll be able to share with you is not just how we are looking at burnout across the country, but in Minnesota, and then quickly pivot to look at what framework we have created in Minnesota across healthcare systems, hospitals, physicians, to understand and act on this crisis. So again, thank you for being here, and let's get started. Obviously, this is an uphill climb, but at least we are on the climb, a long way to go. Trying to advance the slide here, Kim. Let's see. All right. So we are going to quickly cover the environment because I want to put the burnout in healthcare in perspective for you. I'll give you a little bit of background regarding how we look at burnout, and then tell you how we are getting organized in Minnesota to study burnout and act on burnout, and some of our data that we are seeing in 2016 and 2017. So let's start with the world as our stage. For those of you that read the World Happiness Report, great job. It's published every year. If you are not aware of it, please make this one of the takeaways from the webinar today. It's a fantastic reading and resource for all of us. It looks at the happiness data on all countries across the globe. It is done through the Gallup organization, so very robust. And they interview and survey 1,000 individuals in each country. So it's a very robust database. I'll give you a snapshot of what the data look like this year. If you're red, that country is not as happy as if you are dark blue. So as you can see, as a people, the U.S. is quite happy, not as happy as our neighbors up north. So I think we need to learn a little bit from the Canadians. But as a people, we are very happy. So a lot of great data in this international report. The next slide that I'm showing you now looks at the happiness score in the United States over the last 10 years. And as you can see, we are steadily declining. So before we can get to our nurses and our pharmacists and our physicians, we need to know that as a people, as a country, our happiness data and scores are declining. This is another slide from the World Happiness Report. And for the first time, I'm excited to note that they are pulling in mental health. And as you can see, that particular category has quite a bit to do with adult life satisfaction and adult outcomes. So again, some great data and resource for you if you want to look outside the U.S. or just look at all industries and all people within the U.S. So you may be asking, well, is this kind of one of those feel-good, soft, fluffy concepts about happiness? Well, actually not. There is emerging evidence and science regarding what exactly defines happiness. So here's what the neuroscience within our brains tells us regarding what happiness is. So it's the ability to sustain a positive emotion. It's how to bounce back from a negative emotion. It's generosity, and we all know, hopefully most of the listeners are not on your computers or taking another call or on your iPhones, but you are with me. That's mindfulness. And again, a snapshot of what evidence is building. You can see that in this particular picture, there is a brain scan which changes when the subject or the patient is shown positive images. So again, a lot of research happening around happiness and burnout. The other study that some of you may be aware of is the Harvard Happiness Study, which is a very long-standing study since the 1930s, and it hands down showed that the warmth of relationships throughout the life has the greatest impact on life satisfaction. So again, I'll translate all of this to healthcare and physicians and clinicians for you, but again, you know that when employees or physicians or partners leave you or leave your organization, it is solely because of the relationship with their boss or their manager or their peers. So relationships is everything. Again, this should not be a surprise to you. This comes from Gallup, and as you know, we are seeing year after year after year that a lot of our employees across industries are not engaged, or almost 20% of the U.S. employees are actively disengaged. So I'll show you what that looks like. Again, I know that all of you know what this looks like within your organization. So what is the quadruple aim? I think all of you that know the triple aim know that we are now bringing in the reduction in burnout of healthcare staff into the equation to turn it into a quadruple aim. So in Minnesota, when we look at burnout, we don't just look at physicians or advanced practice professionals or nurses or pharmacists. We are also contemplating burnout for managers, leaders, the chief executive officers, the volunteers that work in our clinics and our hospitals, and yes, the board of directors. So we are trying to take a broader view of burnout across our industry. So I'm going to throw some data at you, and again, this is stuff that we are already dealing with and know. Pharmacists, 68% had job stress. Nurses, and this is old. I'm pushing our nursing school and others to come up with new data. Hopefully, we will be able to do something to look at nursing data here shortly. But 34, 37% burnout. Mental health providers, 54% emotionally exhausted. And what does burnout look like for a nurse or a physician or a chief executive officer? They're emotionally exhausted. We are emotionally exhausted. We are detached, and so patients become things that flow through the value chain instead of breathing, living human beings needing our care. We leave for our homes at the end of the day saying, what did I do today? I don't think I contributed anything to anyone. And so that sense of ineffectiveness prevails. So let's turn to physicians and advanced practice professionals. Nationally, the data shows, and this comes out of the Mayo Clinic, and now the American Medical Association is doing some work as well. So nationally, we know that over 50% of physicians are burnt out. What is interesting is that these studies only focused on physicians, and that is something that we did not want to do in Minnesota. So we are really focusing on the entire team. So the data I will show you actually pulls in our advanced trained nurses and also our physician assistants. So what can be some consequences of burnout? So on the one end is suicide. You know, physicians, medical students, nursing students, other clinicians, you know, just giving up and committing suicide might be one end of the continuum. The one that I worry about the most, though, is the bottom right-hand corner, and you know who these leaders and staff are because you deal with them. You know, hopefully not every day, but frequently enough. Is the person that shows up at the meeting but says, I really don't care. I really don't care. So obviously, a burnt-out base of human resources in healthcare will have and is having big consequences in raising costs. The human toll on all of us and our patients is enormous. So it's an important part of the value equation, hence the quadruple aim. So you may be saying, well, so tell us, Dr. Khurana, what exactly is the definition of burnout? And that is what this slide is supposed to do for you. And this comes from international experts. On the right is Christina Maslach's paradigm from Berkeley. And again, she's worked on burnout and has studied this for the last several decades. She is internationally known and recognized as the top authority on burnout. And we are blessed at the Minnesota Hospital Association to have Christina with us on our journey since the beginning of this year. So how Christina describes burnout is the top two boxes of emotional exhaustion. So just feeling tired emotionally. The EQ score is in the toilet because we have nothing more to give. That's emotional exhaustion. And then cynicism is just human beings, either ones that you are managing or the patients that we are seeing just turn into things and not human beings. So those are the two definitions of burnout in healthcare. Fortunately or unfortunately, physicians and nurses and clinicians in healthcare do not suffer from a lack of self-efficacy. So although in manufacturing and other industries, that lower box is also discussed in burnout, in healthcare, burnout is really defined as being emotionally exhausted and having more and more cynicism towards peers and patients. So that's how we define burnout. On the left side of this slide are the drivers of burnout, which is to us more important than just admiring the problem. This comes from Michael Leiter, who is now in Australia. He is also, like Dr. Maslach, an internationally recognized authority on burnout across industries. So the drivers of burnout after his decades of study has everything to do with these 6 factors. For the employee, in our case the physicians or clinician, to control their work life, how good or bad is the workload? Are they getting rewarded? What is the community around them, not just peers, but also the leaders? Is there equity and fairness? And then at the end of the day, is there alignment in values between the worker, the clinician, and the organizational leadership? So that really is the definition of burnout on the right and the drivers on the burnout on the left. So I'm going to turn it over to Kim to poll you to see if you, if you've gained a little bit deeper understanding about what burnout is and how we are looking at burnout. Kim?
Thank you, Dr. Khurana. If you can, I'm going to just remove this poll 1 before question because many of you already completed that, and I'm about to pull up the same question, but but I'm going to ask how you feel about these variables after just hearing Dr. Khorana explain. So if you could take a moment to just complete this after poll, that would be excellent. And then Dr. Khorana is going to take us into, one second here. Okay, here we go. He's going to be presenting on the knowledge of, or on strategies to combat burnout in this next portion of the webinar. So if you want to just make sure that you've completed the before poll, poll 2 before, and then at the end of the webinar, I'm going to pull up an after. Thank you so much. Go ahead.
Great, thank you, Kim. So let's move on to after the definition and thinking about it. Okay, what are we going to do about it, and what, in fact, are health systems across Minnesota doing about this crisis? So we are being extremely data-led. So this is Sherlock Holmes. It is a capital mistake to theorize before one has any data. That always leads to us twisting facts to suit our theories instead of theories to suit facts. So again, we are being very data-led, and we've kind of stolen a little bit from the lean process improvement model, but then given it a little bit of a Minnesota Hospital Association twist. So as you know, we think about plan, then the do, then the check, then the adjust. We have made this model a little bit less dry by pausing, reflecting, and celebrating small and big wins, and sometimes even celebrating risks taken that did not result in a win. So celebration is very important. So our model at the MHA is PDCAC, with that celebration added as a kick at the end of every single PDCA cycle. So before I go on, I have to give a tip of the hat to the physician leader in Minnesota who started us on this journey, Dr. Mark Linzer, who is, again, a nationally and internationally recognized expert on burnout. So he created a survey tool that we used in 2016, which we have significantly modified in 2017 with input from Drs. Maslach and Leiter, the models that I showed you earlier. So essentially what Dr. Linzer was doing at his health system was to study data in all of the physician departments. The physician departments that showed high scores in burnout, he would go in and hotspot them, ask them questions about what tactics can they use to reduce burnout, and spread the practices learned from those departments where burnout was low. So again, measure data, identify departments that are less burnt out, spread those practices, identify the hotspots, and then intervene there. And they changed their spaces, they changed some schedules, they provided scribes. So again, without the data, they could not have started on this journey. Here's an example of what the Hennepin County Medical Center has done with their redesigned spaces. So again, an intervention that came as a result of the data and as a result of the discussions with the department. So that's the model that we took and we spread it across Minnesota, across all of our health systems, hospitals, clinics, physicians, advanced practice professionals, and others. So we want to be data-led, and we are data-led. We will identify best practices and hotspots, and then we will constantly collaborate to spread those practices that work. So for you, in your organization or in your state, the two must-haves before working on burnout on a broad geographical scale is, number one, a guiding coalition. So leaders like CEOs or chief medical officers need to come together and make this a priority and say that, like quality and patient safety, we will not compete on burnout. We will collaborate instead. So that's the guiding coalition we put together in Minnesota, and I'll show you who are the members in a second. And then the other piece that we created was a very robust database and analytic structure. And with me, I have Dr. Heather Britt, who's our chief analyst for this burnout work, And so again, it was critical to have Heather and the analytics machinery and her epidemiological expertise, which we brought to bear to look at the data and start analyzing it across the state. So as you can see here, we have had a great collaborative going since early 2016 around our partners. So we have small hospitals, critical access hospitals. We have very large healthcare systems who have multiple hospitals, sometimes have payers and integrated delivery systems. So we really have a very, very good idea of what burnout looks like and what actions healthcare systems are taking across the entire state of Minnesota. So then we move to the do part of the PDCAC cycle, and this is where we annually collect individual system and site data that we analyze, and then we share back with all of the chief executive officers and the chief medical officers. Through that data, the local leaders identify their top priority domains in burnout based upon their own scores and comparing it to the statewide benchmarks. And then they start acting on their priorities. So we began this journey in 2016. We did the survey, the first baseline survey in 2016. I'll show you how many folks we surveyed in a second here. But then in December of 2016, we asked all the CEOs to articulate the top 3 priority areas that were driving their burnout and the top 3 actions that they were going to take. So then when we check again in 2017, we can easily identify those actions that are bending the burnout curve and making it lower versus those actions that may not be as effective. So the ultimate goal here of the PDCA cycle is to start compiling those actions that are proven to work through our data. So we are not just hypothesizing, for example, we just need to have a yoga room for our physicians and nurses. That's going to work. Or somebody else might say, well, let's give them $20 for them to have lunches together. That's going to work. Well, let's not just hypothesize. Now that we have data across Minnesota, we can actually prove which of these are just fantasies versus which actions are actually reducing the burnout for our healthcare clinicians. And then part of what we asked in the survey was also comments. So we have about 12 to 13,000 comments in the last 2 years. So I'll repeat that, 12 to 13,000 individual comments from our physicians and our advanced practice nurses and physician assistants that we can also mine qualitatively to look at what are really the true drivers of burnout across our state. I'm going to pause and give you a fun story here. Again, this should not be a surprise or a shock to any of you. This is a clinician. I won't tell you what type of a clinician, but it's a clinician that I followed for the whole day on a Friday. They started at 7 o'clock in the morning. I bought them Jimmy John's sandwich at around 12 o'clock. They ate one bite of that at around 1:30, and this picture I took at around 7 p.m. on that Friday evening when this clinician was still plugged in like a robot into their computer with the sandwich hardly touched. So again, as you know and I know, we have clinicians that hardly have time to go to the bathroom, that are just in our machinery, dealing with our electronic health record, clicking the boxes that they are supposed to click, and really turning away from our end person we wanted to serve, our patient. So I'm going to throw some information, and this is a good post-it. So I have a lot of information. Heather has a lot of information. I'm only going to give you a very, very small fraction of what you might need to know to really pique your interest in the model that we have created in Minnesota over the last 2 years. If you want to know more, please reach out to us. And then I had told Kim I was going to tease you with a little bit of a teaser that tomorrow, hopefully, we'll be coming out with a press release about a very wonderful news that we just received this week. And so I've requested Kim to share that press release with all of you. So look for that. I think you will see that we are truly taking this model to the next level across the U.S. and beyond. All right, so let's look at some data. So we asked our chief executive officers, our chief medical officers, physician leaders, what did they think were the top drivers of burnout? And you see those here lined up because we wanted the survey tool to be very responsive to what our physicians and leaders were seeing across the healthcare system. So, and as you know, we are already all surveyed out. An hour ago, I got a survey from Amazon. 2 hours ago, one from Walmart. 3 hours ago, one from my primary care physician. Last night, a survey from my newspaper. So again, I hardly take time to respond to a survey. So we wanted to make the survey very real to what was happening in our clinics, in our hospitals, and in our health system. So these were the top drivers that our chief medical officers and other leaders told us we needed to pay attention to and measure. Then we built the survey tool. We can certainly tell you a little bit about it. Some of the components of the survey tool are for purchase, so I don't feel comfortable sharing the whole survey with you because it's not as if you can just go ahead and do that. Parts of it are proprietary. Some of it come from the Maslach burnout inventory, which, as you know, is the gold standard of burnout across industry. Some comes from Dr. Leiter's work, again, proprietary. And some of it comes from the Mini-Z survey from Dr. Linzer, which is in the public domain. So if you wanted to start somewhere, I would urge you to Google the Mini-Z survey, which is in the public domain, and you can use it for free. All right, so this is what happened in the last 2 years. In the last year baseline, we had 104 hospitals that participated. This year, that number went up to 113. Last year, we surveyed close to 14,000 physicians and APPs. This year, we surveyed almost close to 20,000. So last year, we got close to 6,000 responses. Again, that was a similar experience this year. You may ask, why did the response rate go down? It's the same thing as when I first was surveyed by Amazon, the first time ever. I was like, oh yeah, maybe this is going to be great. Maybe I'll get a gift card. Maybe I'll get my voice heard. I'm going to do this. But then next time around, I say, well, been there, done that. I'm not going to be doing this survey again. So part of it is just attrition, but we can tell you that the 29% response rate is still far superior to other surveys that are done nationally on burnout or other topics, where the average is around 19%. So again, this tells us that physicians and clinicians across Minnesota really want to have their voice heard and really care about their organizations and CEOs and CMOs paying attention to this critically important topic. All right, so here's the bottom line. I'm going to give you a lot of data. You can zone out, but I do want you to take this slide away. So, and I know most of you, if not all of you, are from outside Minnesota. So I'll tell you, in Minnesota, we are less burnt out than the nation. I don't know about you. Check it out, survey, get data, and see where you're at. But in Minnesota, it could be worse. Point number 2, work-life balance is critically important as a driver of burnout. Third, electronic health record is one of the top drivers, if not the top driver of burnout in healthcare. And it's really not about the money, but clinicians care about having time to do what is important for them and their patients, having control over their work life, and also having equity and fairness and having the resources to do their job. All right, so I'm going to take you through some data. I promised to share national data with you as well as one of the objectives. So this is U.S. general population, and I'll tell you what the 3 bars are. Again, the left 2 bars are the definitions of burnout. The 3rd bar is the roll-up, and that's our one metric that we look at regarding the bottom line on burnout. So watch all 3, but really at the end of the day, I want you, if asked, what did you learn from this webinar, I want you to be able to say, yes, the burnout number percentage was X, and a burnout is made up of emotional exhaustion and depersonalization. So if you were able to just say that, that would be success for Heather and I. All right, so let's look at the 2nd bar, which is the same U.S. general population measured again in 2014. As you can see, burnt out on the right went, is the same, but emotional exhaustion went up slightly. The green bar is the U.S. physician survey in 2011. As you can see, much higher than the general population. It was studied again, and this is not our data. This comes from Mayo and other national bodies. So the physicians were more burnt out again in 2014 compared to the general population or compared to 2011. And that's where the high number of close to 50% burnout comes from. And then here's our number in Minnesota, and this is 37% burnt out versus 49%. This is where the highlight comes from. In Minnesota, we have an opportunity and a window to turn this around and again bend the burnout curve. So then here's data from this year's survey, so it's fresh off the press. These are the top 4 drivers of burnout that are respondents, and again, close to 6,000 respondents, so very valid, statistically significant sample. Top driver, work-life balance. 2nd, ability to do meaningful work. 3rd, caring about the organization providing high-quality care. And 4th, ability to control their work life. Now, the reason I put the arrow on the last bar is if you want to give if you want to throw some meal certificates or give some money and say, yep, I want my physicians and nurses and APPs to sit down in the physician's lounge and have lunches on me or free lunches, and that's going to reduce burnout. Well, our data actually says no. This particular slide will tell you that your clinicians are actually saying, don't do the lunch, don't feed me that lunch, give me that hour back so I can get done at 4 p.m. and go to my loved one or my family or my social network that I choose. So again, this data can help us with what strategies are important. Social connections at work, not as important as work-life balance as defined by the individual clinician. I'm going to quickly go through the next few slides, and if there's no highlight there, I'll skip it. Most clinicians, physicians and APPs in Minnesota, we are very thrilled to report are agreeing or strongly agreeing that they're satisfied with their job, which is great. So again, back to that window of opportunity to turn this around and bend the burnout curve. This, for the CEOs that are listening, this should give you hope. I know you're outside Minnesota, so I hope and I hope that your data looks like this. But in Minnesota, the physicians and APPs that responded said that most of their professional values were in fact aligned with their leaders. This could be a medical director, this could be a clinic manager, or this could be the chief executive officer or the leader of the board of directors. But that's great that there's strong values alignment. As you can imagine, most of our respondents in both years said that they feel great stress. This is the one that I want you to take away as well, as far as quantifying the damage that a poorly executed electronic health record can do. And we are really hoping that large, gigantic monopolies and corporations like Epic or others will pay attention to this data and reach out a hand of partnership and say, what can we do to make this tool work for the clinicians better so that they can serve the patients, which after all is the mission and work of this industry. So we look forward to having in-depth heart-to-heart with Epic leaders if they would choose. But again, it's very clear in 2016 we had some clinicians saying they were spending minimal to modest time on the electronic health record. And as you can see, in 1 year, we really pushed that off the cliff here. And as you can see, the excessive and moderately high amount of time on the electronic health record has just skyrocketed. So again, we need to work with the tool and the keepers of the tool to make it work for the clinicians, to make it work for our end consumer, the patient. The starbursts are added up bars to really focus your attention on the key points here. 36% of our respondents said they did not have enough time to do what they consider to be important. Almost a third said they did not control how they work. That's high numbers here. Almost a third said they did not feel that resources were allocated fairly in their organizations. And as you can see, and this, again, we know that we are pioneers on this journey. We probably are the largest national collection of burnout data on non-physician clinicians in partnership with physicians. So we have both physicians and advanced practice nurses and physician assistants, and not small numbers. A full 1/3 of our respondents were non-physician practitioners. So it's very, very critical to bring in the rest of the team when you think about burnout. Here's a quick answer if you were wondering, are physicians more burnt out than advanced practice nurses or PAs? The answer would be yes. You might say, well, where's burnout more, inpatient in the hospital or outpatient in the clinic? Our data shows crystal clear primary care and in the clinic significantly more burnt out than in the hospital. Again, should not be a surprise to you. You are all patients like me, and when we go into our primary care physician's office or provider's office, we know the treadmill that hamster is running on. Here's the answer to your question if you were wondering. If my physician or APP went part-time, will that reduce her burnout? The answer is no. There is no difference in burnout between a full-time versus a part-time clinician. And as you can imagine, for those of you that dreamt of the hours and hours you would have if you turned part-time, you know that that is not reality, especially not in healthcare in 2017. If you wondered, is employment the answer? I'm going to vertically integrate and employ all of the physicians and APPs, and that's going to help them reduce their burnout. The answer is no. There's no difference in burnout between independent specialists and physicians and employed physicians and specialists. Here's something that that we intuitively knew, but the data has proven for us. If you are wondering which category of provider was the most burnt out, look to your left. Female physicians are by far the most burnt out. Then comes male physicians, then comes female advanced practice providers, and then the male advanced practice providers. So there's something going on that we are seeing in our data that we need to pay attention to our female clinician workforce. And that also played out in some of our qualitative comments. So we are taking that as a call to action to have more equity and fairness across all health systems in Minnesota. So here's the model and the framework that we have adopted across Minnesota since 2016. There will be a lot of consultants, a lot of organizations that I know are already calling you your human resource officer, your CEO, your chief medical officer, and the conversation goes like this. Hey, XYZ, I know you're dealing with burnout. National studies show 55% of the physicians are burnt out. We have a proven technique to make sure your physicians and clinicians get less burnt out. For XYZ dollars, we will share our beautiful proprietary model with you. Or you might get this call. Hey, did you hear about this in-person event that we are holding in this beautiful XYZ hotel? Send your burnt out physicians and clinicians to this beautiful location with sprawling hills, running streams, amazing chandeliers, and in 3 days, we will fix them. I would advise you to hang up if you get a call like that. That's where this model comes in. And as you can see, there's a rower of a boat, and that could be a CEO that's rowing as hard as she can. It could be a physician. It could be a nurse, an advanced practice professional. We at MHA and in Minnesota resist the notion that telling a burnt-out clinician or a healthcare staff member to do deep breathing exercises or go take a walk in the nature or lie in bed and think happy thoughts has anything to do with mitigating burnout. So the personal interventions to us are number 3. Way more important are number 1 and 2. So number 2 is having a leadership that prioritizes burnout, that talks about the quadruple aim, and that works on organizational level strategies, which has everything to do with burnout, we believe. So EPIC and EMR, the poor rower, the nurse or the physician cannot control that. You as the CEO or the board of directors could control that and say, hey, this is what we need in the tool to make our clinicians serve our patients better. So that's number 2. And number 1 is making the workflow and the organizational processes better. So again, leadership, number 2. Number 1 is really making organizational level tactics and workflow practice level tactics in the clinics and hospitals better. Once you do that, you're going to see improvement. Deep breathing and yoga, I don't think so. All right, so you may say, well, that's fancy and great, and is it working? I invite you to read our press release tomorrow. Hopefully, it'll show you is it working or not, and hopefully you can have that and refer to it. But I'll give you some data on what some of our health systems saw in 2017 as compared to 2016 as a way to give you hope that this, like any other quality improvement issue, be it hand washing, be it sepsis, be it delirium, falls, pressure injury, surgical events, medication safety event, this too is an industry phenomenon that we can improve using continuous quality improvement tactics that we all know and are so familiar with. So, is it working? All right, here's one health system that showed that we know what tactics they took. Remember, in December 26th, I asked them, and we asked them, what did you do? So we know what they did, and they were able to bring down their emotional exhaustion and total burnout in the span of 1 year. So that's pretty neat, right? So it seems to be working for this organization, and we know what they did, so we can spread those best practices. And I have more examples like that. There's another large system that put in some new workflows around EPIC, and we saw their scores improve around the electronic health record. We have many organizations that have created burnout, multidisciplinary committees spanning the entire system. We've presented to many of those, and we see the great work they're doing, and we are seeing a movement in their scores. So again, we are building a toolkit and a roadmap based upon these best practices. So what do you need to get started? If you haven't started on this journey and you want to, here's what you will need. You are going to need a chief executive officer who believes that burnout is a real phenomenon. If they don't believe, I challenge you to ask them this question: are you burnt out? And have them reflect on that. So our CEOs across Minnesota believe that this is a real phenomenon, and it has everything to do with patient care, quality of care, patient experience, and to retain our workforce for now and for the future. So you need a CEO that believes and wants to work on this. You need a chief medical officer or a physician leader partner, so the two of them in a dyadic relationship can climb this mountain together. Top right, you need a guiding coalition. So in Minnesota, we at the Minnesota Hospital Association, we have a physician leadership group made up of 55 chief medical officers from competing health systems across the state, because again, like quality, healthcare professional burnout is not something we are going to compete on. And then finally, you need a robust machinery to a survey tool, a way to administer the survey, and analytics engines, and the right PhD types to really understand what the qualitative and quantitative data shows you. Because just the survey, doing the survey is not enough. You need to read and understand the survey and connect with your CEOs and CMOs to say, what does this mean? This is what I see in my data analytics. What does it look like to you? And that's the conversation we've been having since 2017. So this is again, the statewide collaborative that we've put together, 113 and counting hospitals out of the 140 or some in Minnesota. So a wide majority of the health systems are participating in this work. So in summary, I want to leave about 15 minutes or so for questions from you. So in summary, clinician burnout is a real thing. It's not, we cannot say everybody across the globe is burning out, so are physicians and nurses and others. We are more burnt out in healthcare than the rest of the country or the globe. And physicians and clinicians are more burnt out than they were last year, and this crisis is getting worse. So it is a real thing, and it has everything to do with patient safety, quality, cost of care, and recruitment and retention of future clinician workforce. The other point I want to make is, please take away that although we only for the last 2 years we've studied physicians and APPs, we are thinking broadly about burnout. So nurses, advanced nurses, pharmacists, physical therapists, CEOs, managers, leaders, boards, and volunteers are all in the bucket. So our scope is broader. We just wanted to start with the physicians and APPs, frankly, because I am a physician and that's what I knew. So you can blame it on me why we started there. The second takeaway is we believe that like hand washing, like sepsis, like adverse drug events, like any other healthcare associated harm, burnout is also a quality issue, and hence a continuous quality improvement model like the one we have at the Minnesota Hospital Association, plan, do, check, adjust, and celebrate, will work. And that's the only way to deal with these broad quality issues, which are by definition both technical and adaptive. Third takeaway, our data year after year over the last 2 years has shown us very robustly that work-life balance, electronic health record, control, and resources for the clinicians are the top drivers of burnout. So again, look forward to getting noticed by the Epic Corporation or McKesson or Cerners of the world, and look forward to having a real conversation about how the tool can help the clinician serve the patient. Because at the end of the day, this industry has got to be about the patient, the family, and the community. And the tool, whichever tool it is, needs to help all of us do that. And last thing, please hang up. If you are thinking about, yes, yoga and having nature trails or having free food as the answer to burnout, what we have heard repeatedly is that focusing only on personal interventions can seem very paternalistic to anybody. So let's think about things that we control as CXOs and leaders within healthcare. It's about organizational system-wide interventions, and it's about practice-level workflow interventions. So the workflows around EMR, the workflows in the clinic, the workflows for baby boomers, which need to be different than Gen X's. Again, our data is revealing some great insightful things around various ages and the differences in burnout between ages and the differences in burnout across specialties. So that is the work that we are doing right now, head down. So that's my last slide, and I would welcome any reflections, any comments, any pushback, which I love, or any questions. So Kim, back to you.
Wow, that was an amazing webinar. Thank you so much, Dr. Khorani. If anyone has any questions, it's *2 to unmute your phone line. You can type your question into the chat box. And Susan says, I'm thrilled to hear this is about a team approach. Beautifully delivered quality presentation. Thanks for caring enough to do this right. Outstanding. And that's also how I feel. It was an outstanding presentation, and I think we can all go forward with takeaways from this presentation. Dr. Khorani, do you know, are there any other state hospital associations who are collecting burnout data or have initiatives to address it?
I think a lot of the statewide and national organizations are thinking about it. As I said, and I think you all heard between my lines, I am getting a little worried about how crowded this kitchen is getting. Talking about burnout, it's a soup that is very delicate, and I'm worried about all these cooks joining the kitchen, and we'll end up burning the soup. So a lot of the national and statewide associations are talking about it. There are new paradigms and frameworks that consultants are calling us about. And the stories I told your listeners about hang up, that's what I did. I mean, I got very, very irritated and frustrated with some of the pitches that I heard. So I think you need to be careful about choosing the right tool. Thank you, Kim, for sharing the Mini-Z survey, which, as I said, is in the public domain. It came out of a hospital in Minnesota and now has been embraced by the American Medical Association. But Dr. Mark Linzer at the hospital in Minnesota created it, and part of why he created the tool with the national grant was to have that tool be in the service of everybody that wanted to study it. Hence, it is in the public domain, and you can use it for free. So again, that's something to think about. We in Minnesota, although the Minnesota Hospital Association has created the table to have this conversation, the real actors and leaders are the chief executive officers and the chief medical officers across our healthcare systems that are leading this charge. So that's the substrate you need, a guiding coalition. Data collection and an engine and a machinery and a survey tool, anybody can give you that, either in the public domain or whatnot. I think more important is, are your systems and your leaders with you and prioritizing this as something not to admire, but to act on?
Mm-hmm. Absolutely. Dr. Khorani, Jessica asks, is there a list of successful strategies that can be shared with the group?
So
maybe somewhere on your website?
Yeah, so we're in the midst of compiling the roadmap. What we do at MHA, and we have about 30 or 40 roadmaps on our website right now on the clinical quality topics. And we are envisioning a roadmap for burnout. So how do you do a gap assessment? How do you, what are the proven strategies that have worked in a healthcare system in Minnesota. As you can imagine, we need data to prove that the strategies work. We do have a few strategies in few organizations that we saw in 2017 that bent the burnout curve, but I think you need to give us about 6 more months when we do our third survey to really conclusively say these 10 actions in small and large facilities actually led to a sustained improvement in data. So again, back to being data-led, right now we have hypotheses, we have a couple of actions that have shown results in the first year, but we really need to wait to make sure that those strategies and organizations can keep that burnout rate down. So I think in about 6 months we should have that roadmap out. And when we do, Kim, you and I talked about this. This will be hopefully an ongoing conversation with your organization. We would be thrilled and honored to share that.
Absolutely. We'll get that webinar scheduled today.
Thank you.
Susan asks, are there other ways we can collaborate? Our Center for Provider Wellbeing signed the NAM commitment, are rolling out the Wellbeing Index of the Mayo Clinic invented in January, are working toward medical Integra designation, etc. We want to learn what's effective and research-based for sure.
So thank you, Susan, for that question. Again, I would say absolutely. What's the least important is what survey tool do you use or what program you sign up for. What is way more important to me is having that coalition of leaders that prioritizes burnout. So I don't know which state you are from, but if that becomes your way of measuring burnout across your state, and that's key. If some health systems in your state have this NAM commitment, some others are looking at Mini-Z, some others are drinking some other new Kool-Aid that a consultant or organization has fed them, you are not going to get to the level of action statewide that we are enjoying in Minnesota. So it doesn't matter which tool you use to survey. What's more important is to have a statewide coalition of CEOs and CMOs that are willing to act together across competitive lines.
Great, thank you so much. Are there any other questions today? Well, thank you so much again, Dr. Khorana. This was an excellent webinar. The recording of this webinar, along with the slides, will be available on our Help Webinar Playbacks page later today.
Well, Kim, thank you.
Yeah.
I was just going to say, Kim, thank you to you and to the National Rural Health Resource